Good afternoon, and thank you for joining another CDI Innovation Webinar where we have our guests today, Mark LeBlanc, excuse me, and Dr. Jason Hom from Stanford, where they are going to be discussing how to build your CDI program around quality. Before I hand it over to them, just a couple housekeeping items. If you do have any issues with your sound, there is a sound drop down in your dashboard. Click on that just to make sure you're either using your computer speakers. If the audio is still not working, you can always call in with your phone using the passcodes that are in there and the dial-in information. We do encourage questions during this presentation that we'll try to get to as many as we can at the end. Also, that is located in your dashboard in the questions drop down. We are recording today, so you will get an archive of this recording and presentation after. And also, if you are interested in looking at the presentation and following along separately, that is in the handout section of your dashboard where you can download that directly. And there's also some other information, fact sheets as well if you're interested to hear more, read more about our products and solutions. You are going to get a certificate of attendance today that if you'd like to submit to a HEMA or ACDIS to apply for CEUs, you can. And then we also have a survey at the end that we would really appreciate your feedback just to know how we did today. So to make sure we have as much time as we can for the actual presentation, I am going to go ahead and pass it over to you, Mark.
All right, thank you. Good morning or afternoon or wherever you are, depending on the time zone. Welcome to our presentation. I'm Mark LeBlanc. I'm the manager for the Stanford CDI program. I've been here at Stanford since about 2018. I'm a nurse by background, and I have, I've been a nurse for 40 years. That's kind of scary. I've been in CDI for over 15 years. Jason?
Hi, everyone. My name is Jason Hom. I'm one of the hospital medicine attendings here. Greatly enjoy working with Mark and the rest of the CDI team as the physician advisor, and look forward to chatting with you all today.
We do have some learning objectives, so we definitely are posted those up here, and hopefully we will be able to accomplish those today. Tell you a little bit about Stanford. If you don't know, Stanford Health Care is located in Palo Alto, California. That's where our main campus is. We have a secondary campus at ValleyCare, which I'll review as well. Part of Stanford Medicine, or at Stanford University, the School of Medicine. So we have, you can kind of see that we are a level 1 trauma center. We're the only one between San Francisco and San Jose, which is an interesting fact. And we do a lot of different types of care here. Our ValleyCare office is in what we call the East Bay, and it is a community-based hospital that has been on board with since 2015. And they too, a lot of the providers are now going between both facilities. So overall, Stanford Health Care opened a new hospital back in 2019. It is across the street from our old hospital, and it is a very large state-of-the-art facility that we're very proud of. And we are now working diligently to turn the 300P, which was the original hospital, into the same state-of-the-art facility with a lot of remodeling and things going on. So our mission at Stanford is to care, to educate, and to discover. Our vision is healing humanity through science and compassion, one patient at a time. And I think as we talk about the quality initiative, it's in our quality care for every patient. So we're committed to provide clear, accurate, and honest information about the quality of care we offer to all our patients. So we really are striving to make sure that the the data, the information, and everything that goes out is accurate and complete and paints an accurate picture. Our CDI program here at Stanford, to sort of talk about our journey, I think our chart sort of helps to describe how we look at CDI here at Stanford Health Care. So we have a upside down org chart. So if you're looking for my name, you have to look more towards to the bottom because that's where I am. So we consider, and Jason's down there with me. So we are here to support the CDI specialists who do all of the work for us on the front lines. And in between the specialists, we have a career ladder. So we have some quality and outcomes leads who you'll hear more and more about as we continue our discussion. We have education leads that actually are responsible for all the education for both provider driven as well as the staff education. And then we have service line leads who help to support that educational efforts at the service line level. And then the specialists do our daily work. So we've been doing multidisciplinary reviews since 2015 of all potential PSIs and HACs. And we have involved both CDI, the clinical partners, as well as coding and quality partners. So the scope includes the mortality cases. So we look at every mortality case from a multidisciplinary perspective. And we also have focus reviews that we do periodically where we, I think we're kind of in the middle of doing a sepsis focus review. We've done some orthopedic focus reviews, and those are, we generally look at them on a monthly basis to see what it is. We've done a COVID focus review. And then sometimes when there's documentation or coding capture guidelines, we'll do focus reviews to make sure that we're keeping those at the forefront. We also have a very large Vizient expertise and engagement from the CDI, and so we do risk model analysis, and we've been doing this since 2017. And we have a tool that we created, which is called the .rcc tool, and it is a tool that is embedded in the provider's documentation that they can use to identify conditions present on admission or even conditions not present on admission. It was mainly developed for our Vizient models and making sure that we're capturing all of those diagnoses, but it also helps to alleviate or helps to keep our query rates lower, because if physicians or certain groups have a lot of queries in one area, then we try to incorporate that into the tool. The tool also is managed twice a year. So if Vizient comes up when they redo their models, we go back in and redo our tools. And we also we're also encouraged from an organizational standpoint, we encourage providers to use it in their HMP and their discharge summary, but we also encourage it in their progress notes if they see use of it there. And we have a fairly high rate of use of the tool, and so it's really been prudent. And Jason, do you have anything you wanted to add from a provider standpoint?
Not too much. .rcc stands for relevant conditions and comorbidities. And as Mark mentioned, it's fired within the HNP and the discharge summary. If you're wondering about how much time it takes providers to fill out, it really depends on the complexity of the patient, length of stay, and other factors. Probably, if it's done meaningfully, a few minutes to fill out.
Yeah, thanks. I think that's probably the biggest, when we developed them, is that in the beginning, a lot of the providers wanted everything listed on the .rcc, and it became such a huge, overwhelming tool that we've learned, and we've begun to really start to hone in on the actual, there's no reason to put certain diagnoses on certain ones if the providers always document it and it's part of their practice. And so there's no reason to remind them. So we try to make sure we take those out of the .rcc so that it really becomes a little more efficient for them to fill out. We did do a CDI collaborative project this year, and we have been looking a lot at our CC MCC capture rates, and we're honing in on the fact that sometimes the data, even though against our peers we may show that we're not as high a level of capture, but if certain elective or short stays can negatively impact that. And so as long as you're able to talk to those, and so we spend a lot of time around that as well. So we really wanted to do a collaborative approach when we look at our CDI program. So we consider ourselves part of coding, quality, and CDI as a core, supporting the clinical providers, and compliance is out there as well, helping us in the periphery. So we really wanted to make sure that we weren't siloed. We wanted to make sure that we allowed providers who wanted us to look at certain cases to make sure that the documentation and the code capture was accurate. We've created a way for them to do that. And we've made sure that we try to make sure that we have a strong partnership. That's really what we're always trying to achieve between all the departments. Back in 2013, they started looking at PSI 15, or the accidental puncture and laceration. And they wanted to make sure that we had an accuracy in capturing the complication. And we wanted to make sure that we improved the patient experience and outcomes. And we wanted to have an honest review of the cases and reflection of the clinical practice. And then we started doing all of PSI 90 cases back in 2015. So we've been doing a quality focus, and we continue to grow that focus and to make the program even stronger than it was in the previous years. So just to give you a little idea of how we do stuff here at Stanford. So the CDI specialists do concurrent reviews and queries for all of the patients, all inpatients, and usually with length of stays greater than 2 days. And then they follow the cases as needed. When the system fires a PSI or HAC, there is a second level review that is done by our CDI quality and outcome specialist. And then pre-bill coding and queries happen, and then there's another review. If there's still a final coded PSI or HAC at that point, then we do another multidisciplinary review, and it includes CDI, coding, and quality. And quality is looking at it to see if there was a patient or a clinical issue that needs to be brought back to the clinical team. We also do pre-bill reviews and queries for any focused non-maximized DRGs. We do multidisciplinary clinical reviews, like I talked about before, for certain focus areas. And we do look at all of our mortality cases as a multidisciplinary team. So we, like I said, we use the 3M software, and when it flags a case concurrently and or by coding, then it flags for additional reviews. Let's see. And we do submit all of our queries. Everybody works cohesively to make sure that we're getting the documentation accurately to reflect the PSI if it needs to be there, or to get the documentation that will help to negate that PSI. So everything that we do is around the patient and patient focused, and I think that's key for making sure that your quality initiatives are accurate. And so we are looking at the documentation, coding is looking at the code. Accuracy and quality is there to help when it is all of those pieces are finalized and validated, that they are looking at it from the quality patient experience, and if there's something to take back to the clinical teams to work on improvements from the clinical side. And so we include nursing, clinical providers, and compliance are all sort of part of this relationship that we have going forward. You know, our CDI teams are the sort of looking, they have a coding knowledge, but they really are looking at the documentation and making sure that we are have the documentation to capture these codes, as well as writing the queries when we don't, and making sure that we're providing education to the providers around the accuracy of the documentation and the need to why we need certain things documented. And all of our work is done around making sure that all of our publicly reported data is accurate. Our coding team are the ones who are out there making sure at the end that the codes are accurately reflected and captured. They make sure that we get all of our POAs done correctly. And then, like I said, the quality team is very vital to the fact that they ensure the messaging back to providers around what it is that we are identifying from a code perspective that impacts the PSI and the data reporting. Anything you want to add, Jason, from that perspective?
Just to highlight the collaborative approach that you mentioned, I think there's a lot of crosstalk on the back end. So there's swim lanes within the 360 program, and different experts, whether it's from CDI, coding, or quality, are oftentimes looking at the same cases and talking on the back end. And then the more provider-facing end, there's a lot of crosstalk as well. So, for example, a lot of times the CDI specialists will present at the quality meetings to talk about trends in the E or trends regarding PSIs or those sorts of things. So a lot of collaboration, both visible within the organization at meetings and also on the back end.
Yeah, that's a great point, because a lot of times the CDI, coding, and quality are all reviewing at the same time and going back and forth around answering questions for each other and providing more information. So we just really, part of the process, I think, is you start to look at these types of enhancing your programs around quality, is to make sure you break down walls, make sure you don't have silos, make sure everything's collaborative. You want to make sure that you have the right skill set, and making sure that the teams are giving the support that they need to utilize those skills. Takes a lot of team building in order to get everything up and running. In the beginning, you have to make sure that it's a collaborative effort, and sometimes that can be really hard because each department kind of has its own workflows and ideas of what they're trying to accomplish, and then trying to make sure that everybody understands the big picture and that we are all trying to accomplish something similar for the organization and the patient, and that it's the importance of all of us working together. And then I think finally it's about being honest and within, having those discussions, making sure that there's chances for enhanced learning, and also just getting lots of feedback from the team and letting them be a part of the process is key as well. So this is kind of, some making sure that you have the essential skills on the team to make sure that you can get the output that you want in an efficient manner. So you want to make sure that it's professional, there's interpersonal process and improvement, whatever way you do that, and your data and technology. And obviously the data and technology piece is what's key to helping drive the work, but also making sure that you have all the right people at the table. I think it's really important when you do any kind of project or any kind of development within a CDI program that you have a lot of good, clear messaging. You have to have goals set. You have to have an understanding of what the importance of the work is. And so I think it was really important for us as a team, and the journey really started for me in 2018 when we began to plan for the implementation of 3M360. And that's really when we pulled, the work had been going on in other formats, probably more technology sporadic, or Excel spreadsheets and emails and all kinds of forms. And we really saw an opportunity, and we wanted to make sure that we harnessed the software to do this work. And so that's really where we started to pull all three teams together to start to talk about what a collaborative effort could look like, understand where in the processes each team would come in, what the expectations were, make sure that everybody felt comfortable in the roles that they were playing, and then also to understand how we would recognize the successes and make sure that those were brought out, and the reporting and our baseline metrics. So we also involve providers in the service lines. We have physician champions in each service line that Jason works with, and we wanted to make sure that we understood what they were using for benchmarks. So it's really important that you understand not only what does the organization, if the organization says, well, Vizniet's our benchmark, or CMS, or something, however they want to do it. But you also need to understand that there are other individual benchmarks that each service line or different one, like MISCLIP, or a lot of people, different providers have different things or different groups. So we want to make sure that we work them very closely. We wanted to make sure that of the ones that we chose and that they used, that we became experts in the methodology and figure out ways to mitigate those risks. So around documentation. And I think that's key as well. And a lot of times it was the quality departments that had a lot of this knowledge base, and we would tap into that as well and help us to learn more about the quality initiative. And then we wanted to make sure that we had a good process for reporting, and we wanted to be able to have like our previous, current, and a comparison data. So it was to make sure that we had some performance metrics that we could make sure that we were watching and keeping track of, and then we wanted to make sure that we communicated well. Anything you wanted to add, Jason?
I think very well said. I think there's a lot of different routes for two-way communication that's mutually beneficial. So I'll give a few examples. I think the CDI website, anyone, whether it's a professional from quality, a provider from any service line, can submit a case if they want it reviewed because they have a question about the coding or a documentation-related issue. We've oftentimes found that just discussion, multidisciplinary discussion of one case can lead to a whole slew of really fruitful conversations. Sometimes we'll have big topics that get discussed at division meetings, at quality meetings. Sometimes when I'm on service, I'm going back on service next week, a provider will just stop me in the hallway and ask about a case or about a particular topic. Sometimes those hallway conversations are very fruitful as well. So I think the key, as Mark highlighted, is just really respectful and consistent communication with all the relevant stakeholders.
Thanks, Jason. Yeah, so then, it's setting your expectations and accountability. So I think one of the overarching expectations, like I've said over and over again, is patients is the focus of the work. And it's definitely our goal is to improve patient outcomes. So when you can try to clear out the documentation issues and the code capture issues, then you can definitely hone in on the clinical issues and allow the organization to really be able to start to say, this is a clinical issue and this is where we need to place some resources on trying to improve that piece of it. And I don't know how it is at other places, but I know when I first got here that there was a lot of questions about our documentation and coding. And so every time there was a blip in some sort of quality outcome, it was always, well, there's something wrong with the documentation and the code capture. And so it took a lot of work and a lot of time and work and partnering to make sure that we got the word out that, no, we're really doing a lot of back-end work around ensuring that the documentation is there and the code capture is there. And so we need to also, and we'll continue to do that because that's what we're here to do, but then to try to help to promote quality, our quality partners, and saying, okay, we need to go back and say, no, this is a clinical issue and we need to start to talk about it. What can we do on the clinical side to help improve these outcomes? And so that's really been a key thing that's come out of all of this work. You have to make sure that people understand what's in it for them. And as any other thing that we do in CDI and probably in any business, you need your senior clinical leadership as well as your senior administrative leadership supporting the efforts. And you definitely need to have report out. And as Jason talked about, our website also has tons of dashboards and progress reports and different things that we develop for all the different service lines around a lot of different metrics, and as well as quality metrics. And it's there for anybody. They can see it at any time, and anybody who has access to our intranet can see it as well. So it's very transparent, and it's out there for all to see. Anything else you want to add there, Jason?
No, I don't think so.
Okay. And then to continue on around expectations, and it's about, we attend a lot of meetings, and I think that's key to making, like Jason said, we'll present. We've been getting more and more time, and a lot of what we've been presenting lately is just the process that we use, because there were so many people in the organization that didn't realize how much work that quality CDI encoding did behind the scenes from the time the patient's admitted till when the bill goes out the door. So just having them understand that piece and starting to trust that we're doing all the things, we're doing peer reviews, we're doing lots of audits of the work and spot checking and making sure that we continue to have a high accuracy rate within all the work that we do. So I think that's been a real key for us. I think that's all I have there. So this just talks a little bit about our focus review process, which Jason is a huge part of. And so we usually will come up with some sort of potential opportunity identified. We'll focus an internal clinical review, and it includes both CDI and coding quality. We give feedback to our partners around it. This is also part of what Jason said, when somebody wants a chart review or multiple chart reviews, that they can put in a request for us to look at all of that stuff. And so the goal of all of this work is, like I said, is making sure that we have accurate medical records for our patients, and that we're reflecting the outcomes from Stanford's work that we do every day. So as anything else you do, if you don't have the clinicians on board, it's not going to be very successful. So we really wanted to have, one of our strategies was engaging the clinicians, and it was a all around respect and collaboration. So we definitely wanted that to be the driving factors that we use when we engage. And like I said, we had the luxury of having provider champions from all the service lines that we could tap into, as well as the senior clinical leadership have been supportive as well. So I think some of the things that we came away with is that I think recognizing that everyone wanted to do the right thing and that we're all on the same team was one of the things that you just sort of have to have as an assumption and sort of base your work off of that. And I think that's come true from what I've seen in our work that we've done today. And we need to recognize that they're super busy and that they have a lot of expertise. And as Jason said, when we built the .rcc, I mean, it does take time. And so we're asking them to spend that time. And so we want to assure that when they spend the time, it's fruitful and that it pays off for both them, the patient, and our organization. And so that's why we put so much energy and efforts into maintaining it and updating it and keeping it front and center. And we want to make sure that we target our conversations, because a lot of times here at Stanford, the APPs and the residents are doing a lot of the documentation, and the attendings are there to co-sign and sort of monitor and maintain it. So we definitely want, sometimes certain topics and target audiences can be very good to when you're engaging with them, and making sure that you include all of them as well. And, you know, like I said earlier, you want to make sure that you share the analysis, which we do monthly with all of our service lines. And we not only create the dashboards, but we give them a synopsis of what we're seeing and where we see potential opportunities for improvement and collaboration, and working with them to help educate and do other things as well. Did you want to add anything, Jason?
I think, as you nicely highlighted, we're very grateful for how engaged and supportive all the clinical staff here are, whether it's APPs or residents or attendings. You know, everyone's very busy. Our censuses are quite high now, even though COVID thankfully has abated. But the overall query response rate in Palo Alto hovers around 99.99%. The meaningful response rate, which includes agrees and disagrees, is currently somewhere around in the mid-90s. We're very grateful about that. And just in terms of the meetings that Mark and I have both highlighted, when you go to provider-focused meetings like division meetings, we found it's very helpful to ask, you know, providers, what are you interested in seeing? And oftentimes people say, well, I'm curious about this data or that data. And that gives you a really natural way to say, well, I don't have that level of granularity that you want. I'd love to prepare it for you. And then you get an invitation to the next meeting. So it creates kind of a positive cycle so that your interactions at meetings with providers aren't simply just one-offs.
Yeah, that's a great point. And I think the service line leads, having a consistent person working with the service lines also helps, because they develop that relationship as well. And sometimes in between meetings, they'll be asked to provide some data for something, a different type of meeting that someone's going to. So it's really great. Sometimes we get invited to meetings that we never didn't really realize they were happening. And now we're like, oh, this is great, because we really need to be at the table here. Yeah, and I mean, I think this just comes from it, is making sure that we're partnering with them and making sure that they understand that we we do have some expertise and that we do provide value for them and can help them to improve some of these outcomes that they're being tasked to work on. And that when they are working on them, that it is truly a clinical issue that they're trying to take on from their side. And you know, the misconception that it's purely financial still is out there after 15 plus years. And you know, I was thinking this morning, and I'll digress just a hair, but when I started back, you know, we didn't really talk about quality so much in the early days. We just looked for that one CC or MCC, and then we moved on. And we worked purely financially motivated. And that's how CDI got its start for people who may not really realize that or been in later. And so to turn that around sometimes can be very hard, especially if you've had a program for a very long time. And you have providers who've been around for a very long time. It's hard to get them to see that. And so making sure that you have those conversations and them understanding how all the work that we're doing and that they're doing is really around the quality issues and making sure that our quality outcomes are accurately reported. Yeah, and so we do have some, you know, like Jason said, we want to make sure that we bring the right stuff to the right meetings. We want to make sure that we, like you said, we're tracking it, we're trending it for them. We're giving them the details when they want it and not providing a bunch of details when they don't want it. So I think that's really a key piece, is learning how to be sure that you're attending a meeting and bringing the right stuff to that meeting and being able to ask questions, and also being comfortable saying, like Jason said, I don't have it, or it's not, you know, I can get it for you, or let me find some other people who can answer those questions for you. But becoming sort of like the person who may not just be the expert in certain areas, but also you can find other resources for them. Did you want to add anything, Jason? Or
No, that's okay.
Okay. All right. So I think it's all about, like I said, we've been talking a lot about going beyond traditional quality efforts, which is, you know, a lot of times just looking at PSIs and validating those. But, you know, the creating a .RCC, making sure that you're creating tools to help make things more efficient as well as improving quality at that time. We're also looking at right now where we just finished a whole project around admission status, and because there was so much just differencing of how that process and the process of applying it, and admission status does have a huge outcome around quality metrics, and so making sure that you get that right is important, and making sure you understand what the guidelines are around it. Here at Stanford, we have a provider experience group that is trying to help make the provider experience better. So it's around technology optimization, so trying to reduce their burden. And then we are also looking at a lot of CMS advocacy. So Jason does a lot of work around that and trying to get some CMS to think about changing some of their rules and guidelines around capturing of codes. Did you want to elaborate any for them? Maybe we can get some people on board to help us with that.
Yeah, I know, maybe I could use the help since I've been pretty unsuccessful so far. But I mean, one example would be, I think as many of you probably have experienced at your institutions as well, one of the most common retro queries to surgical providers is about pathology reports, since the PATH report typically takes a while to come back, as the pathologists are very thoughtful, and oftentimes doesn't come back till post-discharge. And you know, countless surgeons have asked, you know, this seems clinically like a logical system that I have to confirm the pathologist's findings when, you know, the reason I send them the biopsy is to get their expertise, because pathology is the gold standard. So we do have an advocacy project regarding that. We do have another advocacy project regarding pressure injury diagnoses too. That's a relatively common query here based on the wound nurse's documentation. So CMS does have a specific group about reducing documentation burden, and that's the group that we've been reaching out
to. Thanks. And I think, more, we'll talk a little bit about as well some more information. And then PSI 12, the fact that you can't really determine and or query for the POA status. So there's some talk around clinically doing an ultrasound screening, a lower extremity ultrasound screening on transfers and our high risk admissions, so that we can substantiate that there is no clots of DVTs at that time. So, like I said, there's, the data analysis and validation is a big part of quality and the initiatives that we do. Goals and messaging alignment, so making sure that we align our goals with the organizational goals and the service line goals, and making sure that we're all working towards the same sort of goals and with the patient-centered and mission-minded. And then we talked a lot about transparency of performance, so making sure that we have some sort of dashboard and that it is transparent and out there for all to see. And as Jason said, there's a whole advocacy around thinking big. And so CMS has this initiative called Patients Over Paperwork, and they want to reduce unnecessary regulatory burden to allow providers to concentrate on their primary mission, improving patient health outcomes. So, like we said, why do we need to have the doctor write a pathologist? We should be able to code directly from the pathology report. Why do we need to have the doctor write the wound care nurse? Because they're the experts. Why can't we just code directly from wound care? And you can take it to a lot of things. Most medical schools don't teach malnutrition or any kind of nutritional type stuff now. So providers are reliant on, the dietary departments to go in and do those assessments and do those diagnoses. And so why do we need to get them to write it? Why can't we look at patient care from, as we do in the hospitals, and as a multidisciplinary team, and each team member should be able to, we should be able to use the team members' documentation that's pertinent to that type of work to capture codes from and show the outcomes, because they are part of the quality and the outcomes in the patient experience. So that's a biggie that we're working on. Anything you wanted to add, Jason, there? Okay, cool. Let's see. So some high points, just make sure that you take a collaborative approach. We feel like that's really the best way to review PSIs, and make sure you keep your patients at the center of the work. It's always good when you have multidisciplinary teams, and even just all teams and all peers, and just make sure you acknowledge, appreciate, and leverage all the skill sets. Make sure you have clear and manageable processes. Make sure you use data. As we all know, data is key for everything now, and making sure that you can monitor that and to show your program's success or areas for improvement. Make sure you are always taking feedback and keeping everybody as part of the group should be able to feel confident that they can give feedback and that they can ask questions and be able to be part of the team, and just celebrate the success. That's a key that I try to do all the time with every little thing, and we do it in our daily huddles. We talk about personal successes, team successes, and so I think that's key. Anything you want to add there, Selena? Okay. So for us, some of the things that we're continuing to work on is our data validation, which we're continuing to do, socializing our actual efforts, because I think that's been a big thing for me in the last few meetings where we've developed some slides similar to the one I showed early on around what is a documentation review? What does that mean? Who are the people looking at your documentation? How many times? Why are they writing queries? And then, all the work that goes on behind the scenes with second level reviews, and then these multidisciplinary reviews and the focus reviews. And I think that as more and more in the organization understand all the work, I think that they become very appreciative and become less questioning of the accuracy of the coding and the data, and willing to start talking about other sort of clinical issues as well at that point. And then we are looking at readmissions and population health outcomes this year. That's part of some of our quality initiatives that we're going to be adding to our plate in FY22. And that's it for our presentation. I think the next one is a quick poll.
Great. Well, thank you both. That was a ton of information and fantastic information. We have a lot of questions that we're going to try to get to as many as we can. I am going to launch just a quick poll as we start getting into these questions. If you are interested in getting information about quality, best practices, and metrics, let us know. Let us know here, and we will send you an email about this. So let's just go ahead and get into these questions. We had several around the actual tool within Vizient, and then also the tools that, and just generally what tools you are using. Can you kind of go into a little bit more detail around the Vizient tool and how that kind of works with the process and system?
Yeah, so the .rcc is actually a electronic health record tool. So it's like a smart phrase, or it's built within the electronic health record. So they fire this smart set or smart tool, and it then gives them a drop-down menu. So if people are familiar, it's sort of like, so if, like for Jason would fire the medicine one, and then it might say one of the first categories might be electrolytes, and then there might be choices like hyponatremia, and then so as he's clicking, it's kind of a click functionality. So you click on the diagnosis, then it gives you another. Sometimes if it's more acuity, it may be like acute or chronic, and then it clicks all the way down to whether it's POA or not POA. And every one of these, every category and every diagnosis also has free text, because you can't just limit the providers to just the pre-populated one. So they have to have the ability to free text as well. So that's it. And so we build categories based off of Vizient models. And within those categories, we have the diagnoses identified. And then each service line, we work with them individually to decide which of we may have like 30 categories, and they may only want 3 categories because their models that they are based off of, that's all, it only includes like 4 of those categories. So they only want 4. So and others may want 10, and so that's kind of how we built it and how we manage it. Do you want to add something, Jason? That might, I don't know if I'm making sense.
Yeah, no, I think that's well said. I think Mark alluded to this previously, but Vizient does change their models periodically. So they have a different multiple linear regression model for mortality, for length of stay, for cost for each DRG. So we do review those model updates periodically to make sure that the tool, which is embedded in the admission and discharge templates, is periodically updated. In terms of looking at the data, so we not only track, did providers fire this tool within their H&P or their discharge summary, but now we're also tracking what we have deemed like a meaningful use of this tool. So we have a kind of a crude proxy for that, which is, did the provider select at least one diagnosis within this tool? Obviously, I say that's a very crude metric because it could be the case where there were more diagnoses that should have been selected. There are also some times where it probably makes sense not to select any diagnoses within this tool. But we are trying to be as data-driven as possible in analyzing the use of the tool to help inform, is there a particular service line or a particular provider group that we could chat with some more and provide a little more encouragement for.
Yeah, and the specialists also use some of the Vizient tools that Vizient provides as part of their engagement, that they can go in and once they identify the working DRG, they can then go in and look for all of the different diagnoses that could impact it, and then look to see if there's an opportunity to query on any of those. Because a lot of times they're not like your standard CC or MCC or SOI or OM drivers. Sometimes they can be very something you hadn't thought of. So, we try to also, after we've used all the tools we have, we do also take this tool and look to see if there's other opportunities to improve the quality outcomes.
So kind of a follow-up question with the tool and other tools that you're using, which EMR are you utilizing?
Are we allowed to say? We're an Epic shop.
Okay, we won't stay on that one too long then.
Okay.
All right. So another question that we got from Chelsea, what does your staffing look like for CDI? How do you determine how many CDIs you need to complete all the work in collaboration?
Oh, that's a great question. I can tell you what our current model is. So we have 9 specialists who do the reviews on the front end. And those 9 specialists are supported by 4 service line specialists who help to support them in the work. And then there's 2 educators and 2 quality and outcomes. So that makes up the entire CDI team at this point. We have sort of, we definitely look at our review rate and trying to figure out, we always are needing more staffing, and we'd love more. I think the sweetest spot we have right now is the service line leads. They each have about 5 or so service lines, 5 to 6. And that seems to be a fairly manageable to be able to do all the work that we're doing. And from that perspective, so that seems to be a good spot for us. We probably need a few more specialists to get our review rates up, but we definitely are using the 3M tool, and so we use prioritization, and I definitely feel like we are, with the staffing we have, we're getting to the cases that we need to get to, and the ones that we aren't getting to, I'm monitoring on the back end to see if there's retro queries sent, and I'm not seeing that happening, and so I feel like we're probably in a good spot from that perspective, and that's kind of how I try to make sure that our prioritization is working.
Okay, great. So another question that we have from Alicia, your program seems highly integrated. Do you work on site or remotely? And do you focus on productivity as much as the quality of the CDI coding? Because communicating with all those involved would appear to take a lot of time, what is the productivity expectation?
So since the pandemic, we are fully remote. Prior to that, we were on site with 2 days a week remote, but now we're fully remote. So we're no longer on site. we, I watch productivity, but I don't look at productivity alone. So I'm looking at people's reviews, their queries, we monitor how many times they interact with providers. The specialists do. They track when they get a call or they call a provider or do any sort of individual education. So I look at it as a whole picture. So I don't. I'm really working hard before I leave this profession and retire to try to help set the new standard of what is best practice in CDI. And I definitely think it's more around quality focus than it is review focus. So, but I don't have the magical answer, but I will say that the service line leads, that's really the majority of their time is spent in interactions. And so that is the majority of their work, is just putting together metrics and dashboards and meetings and going doing presentations. And so the expectation for them is to be less in doing like the work they don't do reviews in the system per se. They do the escalation of our queries. So they get involved because they're really the ones who have the relationships with providers. So we get more out of their involvement in the escalation process. But other than that, they're mainly just doing meetings and presentations.
Great, and let's, I think we have time for one more question. This is from Tara. In your quality strategy, do you take into consideration the payer's criteria of certain diagnoses as it relates to potential DRG denials? For example, recently United Health Care, which is a big auditor, has put out that they will be using sepsis 3 criteria starting July 1st.
It is not in our current strategy per se. We are definitely next year have some initiatives around what we call the Drg Downgrade denial, where they don't actually deny it. They just say we're going to downgrade the DRG from this one to this one, like throw out an MCC or throw out a CC or change the principal diagnosis altogether. So from that perspective, I think that's where we'll probably get involved with some of more of these individual type payer things, but we have not at Stanford been that involved, and we've definitely been pushing, and I think FY22 is the year that we will be at the table because we're getting more and more involved from that perspective, and I do see a change in the environment that we will definitely be there.
Fantastic. Well, again, the information today has been fantastic, and we appreciate you taking the time to answer all the questions that we were able to get to. Just a reminder for those that are on today, if you could complete the survey, we really appreciate your feedback about the content of today's presentation. If you are interested in learning more about any of the 3M products and solutions, there is an opportunity to complete that in the survey as well if you'd like some follow-up for that. And don't forget, we will be sending out the archive of the presentation as well as the recording, and within that email, you will have the opportunity to register for our next CDI Innovation Webinar, which will be in August. And again, we appreciate it. To both Mark and Jason, do you have any closing statements that you'd like to make?
Thanks for the opportunity to share. We're always willing to do that, and if people want to reach out afterwards, please give out my email address and you can reach out to me.
Perfect.
Yeah, likewise. Thanks so much for the opportunity, and feel free to reach out. You can email me.
Absolutely. Well, thank you to you both, and we look forward to hosting you the next time. So take care, everyone.
Thank you. Bye-bye.